Here's a really nice example of the upper end of the range that you can see for dermatofibromas. This is so huge, I can't even on 2x objective, I can't even fit it under the whole scope. It just goes and goes and goes down, 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 all the way into the subcutis and even trickles into the subcutis. Very large. This is an excision specimen. It was excised initially, I think, because there wasn't certainty clinically. They weren't sure what it was, and they were worried about it because it was a large mass on the leg of a young woman. You can see that the typical features of dermatofibroma are here, but it's easy to overlook all that because you're like, what in the world is this huge cellular thing in the dermis? But let's look at those first, and then we'll go look at the cellular areas. We have nice epidermal hyperplasia over top, elongation of the rete, and maybe a little flattening at the bottom, but not too much. You can see here epidermal hyperplasia towards the periphery of the lesion, and as is often the case, you'll get some kind of hyperpigmentation of the basal layer. Well, I guess we don't really have that much of that here, but you'll sometimes see increased pigment of the basal layer, which goes along with the pigmented appearance that these lesions will have clinically. And then look, as comparison, that's the normal skin out at the periphery. And that's the epidermis over the tumor. Massive epidermal hyperplasia or epidermal induction, a very classic feature of dermatofibroma. Over here, and I think you tend to see this best at the superficial portion of the lesion towards the periphery, you can see collagen trapping. And it's really nice here. And let me see if I can flip the condenser to kind of highlight the pattern here. You can really see the nice large bundles of reticular dermal collagen over here, and then here are the tumor cells, and the tumor cells are intercalating between the collagen and wrapping around and entrapping each individual one. A very nice feature for dermatofibroma. Of course, not totally specific. You can also see you can see some form of collagen trapping in dermatofibrosarcoma protuberans. It usually doesn't look quite like this, but you can see individual collagen bundles entrapped. So collagen trapping by itself is not totally specific, but I find that this kind of wrapping pattern is pretty useful diagnostic feature for dermatofibroma, where you see the spindled and stellate or kind of plump cells swirling and wrapping around each individual chunk of collagen or each individual bundle of collagen here at the periphery of the tumor. And see, from lower power you can see this is where towards the edge. There's normal dermis over here, and here's the tumor. It's at this interface between the tumor and the normal dermis, particularly up in the top of the lesion. That's where you usually see that collagen trapping, okay? All right, fine. Let's go look at the cellular tumor itself. First, you'll notice the vessels. Very prominent, dilated, basically staghorn vessels. Yet another reminder that staghorn vascular pattern, or so-called hemangioparasitic vascular pattern, is not specific for solitary fibrous tumor, which used to be known as hemangioparasitoma. So we see this pattern in many different things, so don't get worked up because you see that pattern. It can be seen in lots of things. It can be seen in big dermatofibromas. It can also be seen in dermatofibrosarcoma protuberans, particularly the fibrosarcomatous form, and many other tumors beyond that. All right, so in this cellular area, you can see that it's very cellular, it's very dark blue, and it goes down a long ways into the deep dermis and even into the subcutis. Cytologically, these cells are somewhat atypical. They're kind of hyperchromatic. They're large and plump. Look at some of those nuclei. This one's not quite as hyperchromatic, but it's a pretty big oval to round nuclei. There's some variation from kind of smaller cells to larger cells, so basically there's some degree of pleomorphism here. These features are totally acceptable and in fact common in dermatofibromas. So I find the presence of large cells that are plump and oval to round in shape, I find those things to be useful pointers towards a dermatofibroma versus, say, a DFSP, which would have very slender, thin cells, and they wouldn't look like this. So the large cells, totally fine. Mitotic figures, even though I'm not finding them right away here, I know they're present elsewhere on the slide. And again, mitotic activity is a common feature in dermatofibromas, particularly the big deep ones like cellular dermatofibromas or aneurysmal dermatofibromas, which is what this is actually. And you could argue that it is hypercellular. Some people might call this a cellular dermatofibroma. I tend to use the term cellular dermatofibroma for lesions that have a very prominent fascicular pattern. But either way, it doesn't matter, because the point is both cellular and aneurysmal forms of dermatofibroma tend to be large, and they tend to go deep into the dermis, sometimes even the subcutis. And if they're only biopsied superficially, they'll often recur. And we say recur, but what we really mean is they'll keep growing. Most of the time, they're not locally aggressive lesions. They're just big. And so if you biopsy just the top of it, say if you did a shave of this thing up here, well, guess what? The patient's still going to have, you know, several centimeters of tumor left in underneath in the dermis. So of course that's going to keep growing. So a lot of times recurrence doesn't mean in this setting, doesn't usually mean that the tumor is rapidly growing. It just means that the tumor is big. I have seen some dermatofibromas, large ones, that did seem to grow back quickly and did seem to be kind of rapidly growing, but most of the time that's not the case. These, the other thing here that you probably noticed already is the presence of abundant amounts of hemosiderin. So here are some little areas of hemorrhage. You can see erythrocyte extravasation. Sometimes there are large aneurysmal spaces. Some people might like to split this and call this a hemosiderotic dermatofibroma because there's tons of hemosiderin but not large cystic blood-filled spaces. I tend to lump that together with aneurysmal dermatofibroma personally. You can do whatever you like in your practice, but you can see there's some hemorrhage and there's a lot of hemosiderin. Hemosiderin, pockets of hemosiderin-laden macrophages everywhere in this tumor. Again, very useful clues for dermatofibromas. Even smaller dermatofibromas sometimes will have focal areas of hemosiderin and hemorrhage, and those are useful clues to the diagnosis of dermatofibroma. And those are both things that I almost never see in DFSP. I rarely, if ever, have actually seen hemosiderin in DFSP or hemorrhage. It's just, and I've seen a lot of DFSP. It's just an extremely uncommon finding in DFSP, but relatively common in dermatofibroma. Okay, so a nice example of the hemosiderin deposition. And in these cases that have hemosiderin and also that have hemorrhage, you'll tend to see a couple other things that are often prominently featured. Not only do you see siderophages, but you'll see foamy histiocytes. Oftentimes in these little kind of blood-filled spaces, you can find foamy histiocytes, usually with a bit of hemosiderin in them. And you'll often see giant cells as well. Giant cells can be seen in any sort of dermatofibroma, but they tend to be more abundant and prevalent, I think, in these hemosiderotic or aneurysmal forms of dermatofibroma. Somewhere over there it is. Here's one right there. And they tend to have kind of the wreath-shaped arrangement of nuclei, often with a little foam on the outside. So they're usually kind of Teuton giant cells. And they may be scattered, they may be abundant, but usually giant cells, histiocytic giant cells, are a common finding in dermatofibromas, particularly the ones with hemorrhage and abundant hemosiderin. So this is a good example of the aneurysmal form, a very large example of the aneurysmal form of dermatofibroma. Let me show you a couple other things from this case. Here's a different section, and you can again see beautiful epidermal hyperplasia, a little bit of that flat kind of blunting of the reedy ridges or tabling of the reedy ridge here. You can see it comes down and then kind of flattens out on the bottom. Up here, the lesion's a lot less cellular and more sclerotic. And if you look in here, this looks quite similar to that kind of atrophic or sclerotic pattern of dermatofibromas that we often see more commonly than this big hypercellular deep form. We see dense sclerotic collagen and spindled and stellate kind of triangle-shaped cells wrapping around the collagen there. So that's a real nice, again, at the periphery of these big cellular lesions. If you look around at the periphery, you'll usually see areas that look much more like conventional dermatofibroma. And here, giant cell, giant cell, giant cell. Giant cell is a very common finding. Again, really dramatic branching, ectatic staghorn vessels here. Abundant hemosiderin. And then, let me show you the deep edge of this tumor, where it interfaces with the fat. This is why people get concerned also. Not only is this thing cellular, it may have large cells, pleomorphism to some degree, mitotic activity, but then it trickles into and looks like it's infiltrating adipose tissue at the edge, okay? Dermatofibromas often do this, even though we know that infiltration of fat is the buzzword for DFSP. DFSP usually has a honeycomb pattern. It deeply infiltrates fat and replaces large zones of the subcutis, leaving little islands of fat stranded way up in the middle of the tumor. Now, you can sometimes see little islands of fat stranded in dermatofibromas, particularly big, deep ones. And I've seen occasional dermatofibromas that are actually entirely in the subcutis with almost no dermal involvement. That's unusual, but it happens. And again, the cytologic features and the hemosiderin and the foamy cells, those things are all very helpful in telling you that it's a dermatofibroma, not a DFSP. For example, I don't care about this, even if this looked kind of more honeycomb, there to me is no way that this tumor we're looking at here could be a DFSP because of all the things I just showed you, the hypercellular, the large cells, the degree of pleomorphism focally, the foamy cells, the hemosiderin, the blood, every feature there argues so strongly against dermatofibrosarcoma. But I often see cases like this sent in where the outside pathologist is really concerned about DFSP, which is part of why I'm making this video. So here, this kind of trickling into the fat, kind of sending little tendrils or little feet of tumor down into the fat, that's the usual pattern that you see of fat involvement in a dermatofibroma. Dermatofibromas often kind of splay into the dermis and kind of send little fingers into the dermis at the edges peripherally, and when they're large enough and go down to the subcutis, at the deep aspect, they often send little fingers down into the subcutis, just like we're seeing here. And again, look at how huge this tumor is. It's not surprising that it spreads down into the subcutis a little bit, okay? But that's the usual pattern that you see there. It just kind of sends little feet down into the subcutis, but the bulk of the tumor is clearly not replacing fat. It's kind of pushing everything out of the way, and just at the edges kind of trickling into the adjacent structures, whether it be dermis or subcutaneous adipose tissue. So don't be worried. This feature by itself is not at all not concerning to me in this context for DFSP, and is actually a common finding to see this form of fat involvement in dermatofibromas, particularly the big ones. And in this case, there's a few immunostains and special stains with it that highlight some nice features. The first one, even though you don't need it, this is clearly hemosiderin we're dealing with based on the H&E morphology, but if you really wanted to prove it, and prove that it wasn't melanin, say, you could do this, and this is a Prussian blue iron stain, which is beautifully highlighting the extensive hemosiderin here in this beautiful bright blue color. So a nice example, I mean, this is better than the control tissue, basically, to have this much hemosiderin. And you can see from low power, just the hemosiderin is everywhere, even more abundant than it looked like on the H&E. Just the tumor is laden with it. And again, this case to me is incompatible with DFSP, but if you were concerned about that, a CD34 stain could potentially help. And you have to be careful though. CD34 here, this is a great example of nice negative staining. Now you might say, well look, there's a lot of stuff staining there, but look what that is. Those are all the vessels in the background. Be really careful. I've seen occasional times where people have misinterpreted a CD34 or other vascular stain as being positive when it was actually only staining a really prominent background vascular network in a tumor. So make sure you recognize this is negative CD34. All it's staining is the normal vessels, which is the usual pattern, but the tumor cells in between are completely negative and devoid of stain. Now, CD34, when it works like this, is great. But the problem is that in some dermatofibromas, it will stain, particularly, it will stain at the edge of the tumor. And the reason is that, let's look, that's the tumor over here. Let's look at the normal dermis. Whoa, it's all red. The normal dermis is usually relatively strongly positive for CD34. All these kind of dendritic cells, some form of dendritic cells, dendrocytes. I've heard lots of different explanations for what these cells actually are, but some form of dendritic cell that lives in the dermis and populates the dermis stains with CD34. And that's why a lot of different fibroblastic proliferations and fibrohistiocytic things can express CD34. So it's useful in certain contexts, but you got to be really careful with it. And of course, it stains vascular tumors and vascular lesions. So CD34 strongly stains the dermis, which is one pitfall. And oftentimes, as the dermis comes up to the periphery of the tumor, like you can see here, those dendritic cells kind of tend to pile up and cluster at the edge of the tumor, and so you'll see this kind of halo of bright staining. Not very dramatic in this case, but in some cases it can be really bright staining around the edges and even into the lesion itself of dermatofibromas. But the middle of the lesion should be completely negative, and so that's the way, if I have that really bright halo on a CD34, you can look to the middle and see, oh, it's negative. And most of the time I don't use immunostains for dermatofibromas or DFSP. In most cases, you can easily separate them on H&E. There are exceptions, particularly when you have a small partial biopsy where you're not seeing the edge, the peripheral edges or the deep aspect of the tumor. Those can be challenging because obviously a lot of the features that I've been teaching in this video are all about looking at the periphery of the tumor, the deep aspect of the tumor. A lot of our clues come from those areas. And I have rarely seen cases of DFSP that had a lot of features like dermatofibroma and vice versa, but those cases to me are a minority. With practice on H&E, the vast majority of dermatofibromas and DFSP can be sorted out from one another without even using immunostains most of the time. Okay? But there is a time and a place for it, and this is an example of when it works perfectly. It's completely negative 34 in the tumor cells, normal positive staining in the surrounding dermis, and particularly accentuated near the edge of the tumor itself. And then here's one other thing. This is not the most perfect example, but I think it's good enough to show another feature that happens, and I feel like it particularly happens in these hemosiderotic or aneurysmal dermatofibromas. This is an S100 stain. Now, it's unfortunate that it's not in a red chromogen, it's brown chromogen, but I think I can still make the point, and actually we can make a second point as well. The first point is that S100 positivity, you will often see clustered kind of positive aggregates of positive cells. These are probably either Langerhans cells or other forms of S100 positive dendritic cells. Usually we see scattered dendritic cells in the dermis on S100 stain. We often see them in a variety of tumors, particularly in skin tumors that are inflamed. The more inflamed something is, the more abundant these S100 positive dendritic cells will be. And in fact, if you do an S100 stain on something in the skin and there's no staining anywhere, no scattered cells in the middle of a tumor or in the dermis, you should stop and check your controls, particularly your internal control, and make sure that stain actually worked. Because definitely these are very common, and you should see scattered dendritic cells on an S100 stain. If you don't, you should make sure the stain actually worked. And I've had a few times where that saved me, and I realized the stain was not working appropriately because I didn't see enough dendritic cells in the background. So that's one thing to point out. And in these aneurysmal type dermatofibromas, the ones that have abundant foamy histiocytes, they tend to also have abundant S100 positive dendritic cells, and they can cluster. And I've seen cases where they really pooled together in the blood-filled spaces and really mimicked S100 expression in tumor cells. That's relatively uncommon, but just know that S100 positive dendritic cells tend to be more abundant. Again, after this video, hopefully you would look at a lesion like this and recognize that with looking at all the features, you probably don't need an S100 stain here. But if you still feel like you're concerned about a melanocytic neoplasm and you wanted to do an S100, just recognize that this is a potential pitfall. SOX10 might be a better choice if you're looking at something and thinking, is it dermatofibroma that's got a bunch of hemosiderin versus some sort of melanocytic neoplasm that's making a bunch of melanin. I would say SOX10 might be better in that setting because it would avoid this problem here. So the second point I want to make is that even if you don't have a red chromogen and you're trying to tell apart melanin pigment or hemosiderin pigment from true staining, usually with some practice you can do that. It's harder to do. It's harder, especially if you're looking at the pattern of immunostaining, but it can be done. And look, even on this video, you can see the color here in the background hemosiderin pigment is different than the color here. The immunostain, DAB immunostain, we call it brown, but it to me has kind of an almost orangey red sort of brown look. And melanin is much more of a true brown. Hemosiderin often does have also an orange or kind of golden color, but still usually looks different and also is more kind of globular and chunky and will also be refractile. And you can kind of see as I focus up and down here that you can see each individual blob of hemosiderin in these hemosiderin-laden macrophages. They're kind of standing out because they're all different sizes and shapes. Whereas the immunostain, it's much more fine, even staining of the cytoplasm and also of the nucleus, because S100 stains nuclei and cytoplasm usually. So again, with practice, you can tell apart usually brown immunostaining from background pigment, but it takes a little practice and you have to look closely, and it's not easy to do from low power. So that's why if there's a lot of pigment, I usually prefer to use a red chromogen if it's available in my laboratory. All right, so that's a good example of S100 dendritic cells in a aneurysmal dermatofibroma.